good afternoon and welcome to the last, sadly, in our webinar series exploring the co-benefits of health policy for other sectors. The last one today is going to be on co-benefits from health and health systems to education. Indeed, we're actually going to take this opportunity to go beyond the education system to look at investing in human capital across the life course. So SDG, the development goals to ensure inclusive and equitable quality education and promote lifelong learning opportunities for all, but also SDG 8 to promote sustained, inclusive and sustainable economic growth, full and productive employment and decent work for all. Now, because education and employment are closely intertwined, and as we will see, the co-benefits from health policy to education and the labour market have key similarities. The intertwined nature of health, education and labour markets highlights the importance of a comprehensive approach in policy making that aligns with the Sustainable Development Goals to maximise their potential co-benefits. Now, in this webinar, we will do a deep dive on the evidence about the impact of health interventions during the prenatal, infant and childhood period and into adulthood to explore the impact of child health programmes on educational outcomes and the labour market before putting these findings into the wider context of co-benefits and health policy making. Now, as ever, we have an awesome panel today to explore this topic. First up, we have Ines, who is a research associate at the Institute for Fiscal Studies in London, UK, and a research affiliate at the Institute of Labour Economics, a non-profit research institute and research network based at the University of Bonn in Germany. Now, Ines will provide an overview of her recent review paper exploring the impact of health and health systems on education. Then we have a tandem presentation from Marc, who heads the cross-departmental research programme on health and health systems at Luxembourg Institute for Socio-Economic Research, or LISER, and Matteo Pintor, a health economist at the Department of Social Sciences, University of Luxembourg. Now, Marc will present their review paper exploring the impact on health on labour market outcomes, and Matteo will be joining for the Q&A. Now, following the presentations, we will hand the floor once again to our discussants. Scott Greer, Professor of Health Management and Policy, Global Public Health and Political Science at the University of Michigan in the USA, and Luigi Siciliani, the Professor of Health Economics at the Department of Economics and Related Studies at the University of York in the UK. Now, as ever, we will then have plenty of time for your comments and questions from the chat box, so please do not be shy. Ask your questions and we welcome your comments, insights and country experiences too. The chat box today will be moderated by my wonderful colleague Astrid Eriksson, who will now introduce a poll question for you all, so we can have a little insight into your thoughts out there in the audience. Astrid, over to you.
Thank you so much, Erica. And yeah, welcome to the audience. Welcome to the speakers. Today we will have two questions for you in the poll. The first is a simple yes, no, don't know question. And it's, in your country, does health policy look to invest in people over the life course? And then we have a second question, which is a multiple choice questions. And it is, are any of the following policies being pursued? Interventions to address low birth weight, investing in early years nutrition, broadening health insurance coverage, addressing the burden of mental ill health, all of the above, or none of the above. So yeah, get your answers in now, and then I'm excited to see the results later. Over to you, Erica.
Thank you very much, Astrid. So we will give you time to answer the poll, and Astrid will come back with the results after Ines's and Marc's presentation. So without further ado, I would like to hand the floor to Ines Lee. Ines, over to you.
Great. Thanks very much, Erica, and welcome everyone. It's a delight to be here. So with the next 10 minutes or so, I'm going to be giving a presentation on my paper, which was published in the special issue earlier this year on the co-benefits from health and health systems to education. So as we all know, health and health systems play a really important part in shaping later life outcomes, like whether you go to school, how much school you get, and how much you learn. What we're trying to do in this review paper is to look at the co-benefits from health and health systems on educational outcome. And all the results that I'll present in this talk are going to be causal findings, meaning the results reflect the effect of health or health systems on education rather than the other way around. In order to do so, what we've done is synthesize the findings from over 70 articles published in the past 2.5 decades. And these findings cover a range of different contexts, from low, middle to high income countries. So the first thing to do when you have a bunch of papers is to figure out a way to categorize them. And the way we've done this is to look at 2 dimensions. The first dimension is the timing at which health is measured. And this is reflected here in this gray row at the top of this slide. So what you can see is that I've sliced up timing of health along 3 sections. The first stage is the in utero stage. And this reflects any health condition even before you're born. And in particular, it reflects the conditions or the environment that your mother might be in while she was carrying you. The second stage is the neonatal and infant stage. So this is what happens after you're born, but before you turn 1 year old. And finally, the third stage is the childhood stage. So this is any time after you've turned 1. And typically these papers focus on, between 1 year old to kind of primary school age, because understandably, the educational outcomes kind of stop being measured beyond university years. The second dimension is how the source of variation in health. And given the topic of the health policy special issue, I've just simply divided health by health and health systems. Now, each of these cells in this table give you an example of the different kind of factors or shocks that these papers study. So for example, just to pick a random one here in the middle, a big literature focus on answering the question, does birth weight when you're born, does that matter for later life outcomes, such as how you perform in primary school, secondary school, and so on? So that's one of the examples of a factor that we'll look at the findings of in a little bit. So in terms of mechanisms and framework, this is the kind of picture I would like you to have in mind as we go through the findings later. So on the left-hand side here, we have a purple box and a green box. In the purple box represents health across different stages. And we see 3 icons here. We've got the in utero period, as we just saw, the neonatal one, and the childhood one. The green box represents health systems. And there's an arrow coming from the green to the purple because understandably health systems, so things like whether you have good access to good high quality hospitals and healthcare, whether there's universal health insurance in your country, those type of healthcare infrastructure affects your health attributes at different stages. And that's why there's an arrow coming from the green box to the purple box. On the right-hand side here, we've got a blue box representing educational outcomes. And in the literature, across all of these 70 plus papers, there are very standard ways of measuring educational outcomes. So things like, maths and English scores in secondary school, whether you complete high school or not, and whether you enroll in college. And admittedly, some might argue that these educational outcomes are somewhat reductive and we can have a more holistic view of education. But the benefit of these simple measures is that we have good quality access to either administrative data or very high quality survey data. So we can measure these outcomes without much error. So the question then becomes, what is happening in between the purple/green boxes and the blue box? So in this paper, what we want to focus on are 2 paths. The first path is a direct effect. And what this basically means is what is the straightforward route between health and your educational outcomes? And a simple story is, your health at birth or at a different stage would affect your cognitive abilities, which then affect some kind of educational outcome. The second path is an indirect effect. And what indirect effect basically means is that your health attributes at a certain stage might change your behavior or your parents' behavior, which in turn affects educational outcomes on top of the health conditions that you might find yourself in. So for example, if a parent discovers that a child is born with low birth weight, they might, invest more or take some actions to try to ameliorate that effect. So that would be an example of an indirect effect. Okay, great. So now let's jump into the findings. As we saw, the first stage is in utero health. And there's a bunch of papers asking the question, what happens to the children of women who are exposed to a certain shock when they're pregnant? And unfortunately, most of the shocks that these papers studies are negative shocks, as we'll see in a moment. And there are very few papers studying positive shocks. And the general finding is confirmation for something called the fetal origins hypothesis. And what the fetal origins hypothesis says is that prenatal conditions and environment can have permanent effects on your physiological and metabolic development, which in turn, as we'll see, will affect educational outcomes. So here's a kind of a sample of the different findings that you see in the in utero health literature. There's a big literature looking at documenting the fact that offspring to mother who are exposed to the 1918 Spanish influenza in utero are less likely to complete high school. And this started with Doug Almond's paper in 2006, and subsequently there have been a lot of papers documenting a similar pattern, not just in the Spanish influenza case, but also different cases of influenzas and viruses and so on. There's also a lot of literature looking at the impact of prenatal exposure to conflict and wars. And perhaps unsurprisingly, what you do find is that offspring whose mother were exposed to that when they were pregnant, they also achieve lower educational attainment, even if this is measured 4 or 5 decades down the line. There's also big literature looking at nutritional constraints. So typically the papers here would look at what happens if your mother were pregnant with you when there was a famine going on, or if she was fasting because of religious reasons at a critical period in pregnancy. And again, unsurprisingly, what these papers do find is that these nutritional constraints dampen educational performance, not just in the medium run, which I'm very crudely defining as how you do in kindergarten or primary school, but also really long run effects like how you do whether or not you go to university. So yeah, that paints a somewhat gloomy picture, but fortunately there is a few papers out there looking at more positive shocks. And one example is this paper by Miller and Werry. And what they look at is what happens if my mother unexpectedly gains access to health insurance while she's pregnant. And they look at the impact of gaining access during the rollout of Medicaid in the US, and they do find that this has a positive effect on their offspring. All right, so let's move on now to neonatal and infant health. So as a reminder, this is anything that happens after you're born, but before you turn 1 year old. And there are 2 key findings that I would like to highlight when it comes to this literature. The first finding is that babies born with low birth weight are likely to have worse educational outcomes. Now, of course, the relationship between birth weight and educational outcomes, it isn't linear. There's going to be, a stage where low birth weight is dangerous, then perhaps an optimal range for birth weight. And then if you're past that optimal range and overweight, that has consequences as well. So the findings here all refer to that really low birth weight range, which typically is defined as below 1,500 grams. So the findings here are quite broadly showing that if you're born in this low birth weight range, a small increase in your birth rate has a positive effect on educational outcomes, which is another way of saying that basically being born in this range is quite detrimental to long-run educational outcomes. And crucially, there are also quite a lot of, there's evidence that these findings have heterogeneous effects, meaning that the impacts are even more negative to family of low socioeconomic background. The second finding is that health interventions, when needed at birth, improve medium to long-run educational outcomes. Now, we just saw on the previous slide that being born low birth weight, it can be costly, not just for educational outcomes, but for further things. And there's now, as a result of that finding, a lot of papers then look at, hey, does it make a difference if we treat babies of low birth weight with more severe medical interventions? And the answer is yes, there is a positive effect. In particular, if you're a child with low birth weight, being assigned to a neonatal intensive care unit where you get specialized treatment and more attention helps improve your educational performance in secondary school. You're more likely to go to college. And surprisingly, your siblings also benefit from this. All right. So finally, let's move on to the childhood health stage. And this is anything after you're 1 year old. And there are 3 key findings that I would like to highlight. The first is that access to health insurance in childhood for children and or their parents improves educational outcomes in the short to medium run. And this is particularly true, perhaps unsurprisingly, for low-income families. The second finding is that there's lots of papers looking at the impact of water, sanitation, and hygiene interventions, also called WASH interventions, in particular in low-income countries, and looking at how that might improve educational outcomes. And what they tend to find is that it decreases the prevalence of diseases and increases school attendance. And then lastly, there's also quite a few papers looking at the importance of nutritional sufficiency and stability. And all of these show that it's really important for academic success, both for children and high school students. So finally, so just to wrap up, what we've seen is that health and health systems interventions at various stages of life, from in utero to childhood, have a significant influence on medium to long-term educational outcomes. And these impacts vary across gender and socioeconomic status, which kind of illustrates how health and health systems can exacerbate or mitigate educational inequalities. Thank you. I will wrap it up there.
Thank you very much, Ines. Very, very interesting findings. So let's see how this compares to the labour market. So Marc, I'm going to hand over to you now.
So I'm going to present work which is the result of collaboration with Matteo, who is on the call as well, and Elena Fumagalli from University of Utrecht. So we have done a review, a systematic review, which is also published in the special issue in Health Policy. And the purpose there was very much to provide a comprehensive global review of the mainly causal evidence here of running from health systems to labor market outcomes. So we tried to, in doing so, we looked at methodological challenges and how the studies have tackled that, but this is not the methodological side is not the focus here of the presentation. I'll just present the essence here in terms of substantive results and relationships. So let me start with the conceptual framework. Conceptually, intuitively, this is a clear relationship, you know, running from health to labor market outcomes. But of course, between that and around that and going in both directions, there are different relationships going on which complicate the seemingly simple story. But I can already flag that, you know, the theoretical prediction of the impact on wages and labor supply is a little bit mixed there. And also I've indicated here what the theory, economic theory, predicts when it comes to the impact of health on wages as one important labor market outcome. That is clearly an increase, whereas the expected effect on labor supply, by which I mean hours of work or employment status, unemployment, that is a little bit more ex ante ambiguous. Why is that? I come to that in a second as to why is that the case. So what connects health and labor market outcomes? Now it's quite intuitive to understand that the healthier you are, the more productive you can be. Yeah, the more you can produce with a given input. To the extent then that the labor market rewards your productivity with a higher wage, then that translates into higher wages. Similarly, with human capital, healthier children are better placed to attend school and absorb information over a lifetime, and that should also translate, if markets reward that, into higher wages, higher earnings. The effect on labor supply is a little bit mixed because you have two things going on. Obviously, when you're more productive, you can earn more, and that so is an incentive to supply more labor, you could say. But on the other hand, if you're more productive, you could earn the same by putting in less. So, and you could use that saved time for other things that also add utility and welfare to your life. So these two effects work against each other, and it's an empirical question: which one is the dominant effect, and what's the net effect here? But you also have other things going on here in this still simple conceptual framework. an important aspect is, of course, that the other direction. No, it's not only going from health to labor market outcomes. It can also go in the opposite direction. No? Our wages, our earnings, and the income we gain, and the nature of our work will affect our health. So that hence the other arrow. And we need to then, of course, disentangle the effect from health to labor market outcomes. Healthcare interventions, healthcare affect health, and in doing so, they can translate into labor market outcomes. Health insurance has a more complex role here. Of course, it can provide access to healthcare and hence improve health, and then trigger down into labor market outcomes, but it also can directly affect health. Not necessarily always in only positive effects, but there's also this moral hazard that by having insurance, you could be incentivized to be less careful, no? Because your health risks are taken care of, and there is potentially a direct link even to labor market outcomes. Let me come to the evidence. So we have reviewed systematically, if rapidly, a set of 110 studies starting in 75, and as you see here in the left-hand bar, the evidence has grown. So, and remember, we set a bar there. Now we really wanted to look at good quality evidence of the causal impact here. So there's really is an active area of research. The evidence on the whole is good. And though when you look at the geographic spread of that, we see a lot of the usual suspects, no? Because this empirical work is conditional on availability of data, and hence, most research gets done in high-income countries, no? Where there's usually better, more fine-grained data to assess this. What is the distribution of the studies by exposure? So what kind of health outcomes indicators have we looked at, and what kind of dependent variables on the labor market outcome side have been looked at? So this is just a quick snapshot here. On the health side, general health status is a very popular indicator. Mental health increasingly as well. Others have less been examined. On the outcome side, there's really a range of labor force outcomes that people have looked at: employment, unemployment, so labor supply, hours worked, but also wages, and a set of other indicators. And let me just skip this one. This is just really to show that if you distinguish the effects in all the effect sizes that you gather from the studies, and one study may have more than one effect estimate, plus so the positive effect on labor market outcomes is overwhelming here, but there is also a null effect in some studies and a negative effect. So it's a little bit mixed, but overall the evidence is really positively contributing to what we would expect and hope to be the case. Just giving in the last few slides just a flavor of the magnitudes involved, some very selected quantitative examples, so we get an idea. We can't have, given the heterogeneity of health outcomes and labor force outcomes, we don't have one meta-analysis synthesis figure here. That's beyond what can be done. So hence giving a flavor of what some of the research shows here. For instance, in Eastern Europe, we had shown that general health status reduces, a poor general health status reduces employment probability by 12 to 35% in Eastern Europe. So a set of countries we looked at in Eastern Europe. A number of NCDs were looked at. Chronic disease onset increases the probability of retirement by 30%. Disability is a topic that has been studied, for instance, in Indonesia, where the onset of severe physical limitation has led to a 6.8% percentage point increase in the likelihood of exiting employment, and a reduction of hours even to a larger extent by 15%. Let me just skip to the next one. This is just a non-exhaustive list of things we looked at, we extracted from the literature. It's interesting to observe that when it comes to mental health, that on the whole, mental health sometimes have a larger effect size than some of the physical health conditions where you can compare that. Now, for instance, in Australia, a 1 standard deviation decline in mental health is related to a 30 percentage point reduction in employment. Occupational environmental health, just to pick out here one again, the importance of temperature, yeah, as a health risk. High temperature, a 1 degree increase in a measure of high temperature. So this particular index reduces hourly output by 5% among Indian rice harvesters. Yeah, just to wrap up, I couldn't enter into the details of all the studies there. There's really a lot of them in the paper if you want to have the details. On the whole, I think in this area of labor market outcomes, the evidence is fairly solid. It could always be better. There's always need for more research, but also in recent years we see the quality of the evidence having improved, showing that there are important health impacts on labor market outcomes, especially so for wages and earnings. But that's what we would expect, theoretically. We don't necessarily expect, as I said in the beginning, that labor supply increases as a result of health, because there are these two counteracting effects going on. Hence, if you're interested in making a case for co-benefits of investing in health and the health system onto the labor market, then yes, I think we have a good case to make. Last point, not emphasizing here, but I alluded to it, that really I think has a good development and growth in the literature and in the methodological development as we observed it in the literature. I stop there. Thanks very much. Erika, over to you.
Thank you very much, Marc. Yes, making the compelling case for investing in health, something that I really love to hear. Okay, so Astrid, I'm going to go back to you now to find out what we found out from the audience in terms of the policies which are being pursued or not pursued or might be pursued. So yes, Astrid, let us know the results of the poll.
Thank you, Erika. And yes, I just got the poll results. So for the first question, in your country, does health policy look to invest in people over the life course? 63% of the audience said yes, and 20% said don't know. They said no, and 17% said don't know. And for the second question, are any of the following policies being pursued? The majority said, 44% said all of the above. So that's interventions to address low birth weight. It's investing in early years nutrition. It's broadening health insurance coverage. It's addressing the burden of mental ill health. And then finally, I'd like to highlight that 9% said none of the above. So that's my take from the poll results. Thank you.
Thank you. It's somewhat heartening, isn't it, that almost half of the countries represented in the audience, or half of the respondents in this poll at least, said that we're doing all of the above. Because we've got some real scope there for co-benefits. So now I'm going to hand over to the discussants. Luigi, I'm going to come to you first. So what are your thoughts? Please do share them.
Yeah, thank you, Erika. So I'm going to put the two presentations into context, just to say that these two presentations are part of a broader plan and a special issue that I have co-edited with John Silus, where we try to answer the question on how health and health system can contribute to other sustainable development goals. And the whole special issue is framed around the idea of co-benefits, which we have already discussed. And what we have tried to do in the special issue is to evidence these co-benefits. So we had 9 articles. 2 you have already seen them. So if you think about health shocks and how this affects some SDGs, one is through education, another one is through labor market. We had another webinar last week, which was on poverty. So what came out of that is that if you have health shocks, these can affect poverty, which is SDG 1. And some of these important mechanisms, can go precisely through labor market or education. But one that was not mentioned today, because it's a distinct one, is through out-of-pocket payments and catastrophic payments. So any health interventions that can reduce catastrophic payments can generate a co-benefit in terms of reduced poverty. So that's another article, which is on SDG 1 on poverty. There is another article which is on economic growth, which was written by the same authors as the labor market one, which is Marc, Matteo, and Elena. This article, in my reading, what it says is that there is like a strong correlation between growth and health. But what is really difficult to disentangle is whether is it growth that affects health because you have more resources and this improves health, or is it health that affects growth because you have through better productivity, for example. So the latest evidence seems to suggest that the effect is positive, so that better health affects growth in that direction, but the earlier literature seemed to be saying the opposite. And what it is also clear, I think, from this article is that there are still methodological issues. So the results still remain a bit sensitive to the countries selected, the measures, the health measures, which often is mortality or life expectancy, and the modeling strategy. So that's in that sense, the evidence there on growth is a little bit more shaky relative to the one that we have seen, for example, on education, labor market outcomes. So that's another article that is out there in the special issue. We have another one which is on SDG 16, which you may remember that is the one on institution, peace, and justice. Only yesterday, the Nobel Prize in Economics were announced, and the winners, they had the Nobel Prize mostly for their work on institutions. So we have one article there in the special issues that tries to link how does health and health system affect institutions. And there are like 3 different literatures that have been identified. One is on social capital, which again is empirically quite difficult because you can have social capital can affect health and health can affect social capital. So there, I think, again, a few empirical studies managed to isolate the effect that says, like, actually, if you improve health, that also leads to better social capital. So there is a positive benefit there. There is a separate literature on risk of conflicts. So some studies have shown that more health spending or more public spendings reduces the risk of conflict. So that's another positive co-benefit. And then there is another literature which shows like a strong association between health and political participation or voter turnouts. So that's there seems to be like another potential co-benefit. So those are already 5 SDGs and co-benefits that we have tried to map. We have 2 more articles on environmental co-benefits, which we have covered in another seminars, another webinar 2 weeks ago, which tries to identify green interventions from a healthy. If you have a green health system, this could generate positive co-benefits to the environment. And then we had another one on SDG 12, which is responsible consumption, which shows that if you can reduce meat consumption on a health ground, then this can generate a positive co-benefit in terms of reduction in pollution through the reduction in production of meat consumption. And then we have 2 more. One is on gender inequalities that is also already published. And then we have one more that is going to be coming out quite soon, which is more broadly on income inequalities. And there we take the lens through the financing of the health system and the redistribution that you can pursue through the health system financing. So to sum up, I think as a whole, through this special issue, I think we have done like a good job at evidencing quite a few of these co-benefits. So we hope that overall this can strengthen the case for investing in health. Thank you very much.
Thank you very much, Luigi. Yes, it's mapping all the co-benefits. It's quite some serious undertaking that you've been working on there. Scott, I now have to turn to you because we have all this wonderful evidence. How are we going to bring it into practice?
Well, this is why I was so cheered by the poll, actually, because the thing that's really striking about education compared to health is that it's really quite hard to announce that you only care about your own health, because on some level you understand that you want drinking water and hospitals to be available. Education, it's a lot easier to only care about your own kids. Education is a key mechanism of social stratification. One of the best things I can do for my child is make sure that they also get into a good social class at the expense of somebody else's child. So when you look at education, your default, if you're a political scientist, is to see this as almost a perfect exercise in collective selfishness, in making sure that your own children get a good education, and then maybe you feel charitable about other people's children. That's why it's so interesting that you see across a lot of the rich democracies in particular, but by no means alone, increasing investment in children per se. And I think a lot of it is the kind of intuitive, not simple, but intuitive connections that these papers have found in the sheer weight of this evidence. When we were working on a different project on aging and social policy, we found the same thing, which is that more and more democracies are shifting expenditure sort of down the life course, away from a very, very expensive old age and towards more thinking about how to go all the way from in utero through to death with a comprehensive policy package. And like I said, I'm a political scientist. That surprised me, right? This involved a bunch of countries making really good decisions about their collective economic fate and about the collective health and success of their populations. And it's always harder to do that than it is to simply make decisions about how you personally will do the best for your children. So I'm cheered. I know that's not usually the language we use in these kinds of conversations, but you're seeing a combination of an intuitive story with really high stakes for fiscal sustainability and for economic growth and for people's lives, and an increasing combination of not just data and intuitive stories, but also action. And I'm a specialist in the high-income democracies, but you're also seeing it in thinking in middle and lower-income countries as well. So carry on.
Thank you very much. Yes, it's nice to have a bit of good news, isn't it? So who'd have thought? Who'd have thought? Clearly we are making the case. So brilliant. Okay, so now I'm going to hand over to you. I noticed that the chat box has been quite lively. Hopefully you've been getting your questions in. If not, I recommend you do it now to avoid disappointment. But in the meantime, I'm going to ask all the panelists to switch on their cameras so we can see their beautiful faces. And we're going to ask Astrid to tell us what's been going on in the chat and to feedback some questions. Thank you very much. Over to you, Astrid.
Thank you, Erica. I am going to start off with one question, and then that will also give the audience to get more time to get their questions in. So we've heard a lot about the opportunities and strengths today, but it would also be interesting to hear from the speakers in terms of what are some of the challenges for implementing and sustaining co-benefits in practice. So I suggest we start off with that broad question, and then we can see what the chat box says afterwards.
Okay, thank you very much. Okay, we'll go on to a bit of a sort of like sad note then. So what are the challenges here? Ines, over to you.
Good question. That's a really good question that I must admit I haven't been thinking about in detail. So take this with a pinch of salt. I think from my perspective, the main challenges are prioritization from a government standpoint and from a fiscal perspective. So as we've seen from the results, there are a bunch of things that one could do and a bunch of levers that you could pull. And the question then is kind of like evaluating what are the kind of policies that get you the returns that you'd like and how much those policies cost. That's kind of challenge number one. And one of the shortfalls of the papers that I just summarized is that while we're good at documenting the impacts of certain interventions, we're less good at assessing the return on investment. And the kind of typical way of doing this in the economics literature is saying, especially in the case of the effect of health on education, is measuring the returns to health through things like income earned in adulthood and using that as a very approximate measure of the returns to education. So as you can see, the link here is quite long. So that's just one example of how we could get better at assessing return on investment. And I think in turn, that would help with the prioritization issue and help with like the discussions around fiscal spending and how we want to prioritize policy interventions to address the issue.
So yeah, making the economic case for investing in health, yeah, and having the indicators we need in order to show the benefits. Okay, so Matteo, over to you. Is there anything you would like to add from the perspective of
yes.
workforce?
Yes, I completely agree with what Ines just said. It is challenging to have a full portfolio of possible investments adequately measured in terms also of the co-benefits that they have. A broad challenge, let me remain at a more broad level, let's say. The fact that in this literature we see that there are co-benefits and that we estimate these relationships really means that there are outstanding benefits which are not yet exploited. This is what creates these correlations in the samples of the data that the studies use. So in a sense, the presence of co-benefits means that we are not yet sufficiently good at putting in place health systems that allow people to reap the benefits, to really capture these co-benefits. In a sense, what we wish would be a world in which we have countries with health systems in which all the co-benefits are zero, in the sense that we don't see them because they are already operative. So this is the goal. And this, by the way, to me means that investment in health is really a collective action problem, in the sense that voluntarily, in many settings, individuals probably do know that there could be paths towards better economic success and health, but there are barriers. There are institutional barriers, market imperfections. Health economics has taught us that really delivering healthcare services is a complex enterprise that market cannot do alone, for example. And so reaping these co-benefits really means that policymakers should care about the institutional aspects of healthcare services, but also of support to families and communities in their typical activities of producing healthy environments. So we mentioned social capital before. This is also an important aspect of the determinants of health.
So, Matteo, thank you very much. I'm going to have to come to you, Scott, with this. We're talking about collective action. We're talking about evidence to inform policy making and the challenges of getting evidence into policy making. So I'd be really interested to hear your thoughts.
Well, I'll go back to my top line from the poll, which is that to some extent it's working. And every country has idiosyncratic ways in which it's working. But I think what it boils down to, especially in Europe, is that there is a lot of government preoccupation with essentially hours worked, with broad demographics. If you just draw a straight line, there won't be anybody in Austria in 100 years. And governments are concerned about this. And so I think the conversation about fiscal sustainability in this demographic context is leading to some more public-minded policy than you would otherwise see, and an openness to hearing about logics that, for example, healthier kids are going to do better in school. And also, if you have an increasingly scarce resource like children, you might want to invest in upgrading them, to be blunt.
I'm going to have to I'm going to think about upgrading my children now. So how am I going to achieve that? Okay, Luigi, is there anything you would like to add?
Yes, sure. Just very briefly to reiterate a couple of points. So I think the main problem there is that when we think about health system, we say, well, the health system has a return on health, and we stop there. So I think in some way the idea of the co-benefits is to try to bring this evidence to the right people and in the right discussions. So when the Minister of Health negotiates with the Minister of Finance, these are the right people. And but then there has to be the right discussion when they discuss the resources. So in that sense, that would be one way to try to move forward now that we have gathered this evidence, and we'll hopefully carry on doing that.
Okay, thank you very much. Astrid, I've noticed questions have been popping up, so I've got to come back to you to find out what's been being discussed in the chat box.
Yes, you're absolutely right, Erica. Thank you to the audience for getting the questions in. I've tried to group the questions into 3 categories. So the first is if we could maybe broaden the scope a bit and talk about low and middle income countries. So first of all, can you elaborate on how health benefits can manifest in low and middle income countries, and also sort of related to that, if in your opinion, from your research, what would be the best investment in, for example, a low income country? So that's the first topic. The second is sort of what to do next. Having identified the impact of health on education, what are some of the measures that you have identified on reversing, for example, a negative impact? And how would you prioritize, from hearing all the evidence today, what to do next? And then sort of a technical question at the end in terms of moderating effects. Maybe Ines or Matteo can talk to this. Did you find any moderating effect on of ideology on the association between institutions of health and education?
Right. Okay. Quite a lot of quite a lot of ground there to be covered. So, Matteo, I'm going to come to you first.
Yes.
To mix things up a bit.
Okay,
Come to
let's
you.
begin with what's probably the most difficult question, that is, or at least I perceive it like that, the role of national ideologies, which is difficult to measure. We're talking about comparing countries, which are coarse broad units of observation. That's not easy. There is a wonderful paper done many, many years ago by a demographer, Caldwell, on what he called the health achievers, special health achievers, countries that manage to improve health at very low income levels. And this, to me, remains a very good study to understand some of these issues. And he said, look, countries that have an appreciation for secular education, countries in which women have large, strong level of autonomy on personal decisions, professional and personal decisions in the families, and countries with some long-standing grassroots politics tradition in which the communities expect and want and pretend good healthcare at the local level. These are the countries that manage to increase life expectancy at very low income levels and converge also to countries that are much ahead of them in terms of economic growth. So if you think about that, you could say that then these probably are also the countries that will reap these co-benefits more. This is more a prediction than a finding, I would say, but I would connect to that. And then if I can briefly mention on the, let's say, policies in low-income countries, this also fits to what Luigi was saying. In low-income countries, there has been, I think for quite a long time, the preoccupation, another demographic preoccupation of the one that Scott was mentioning, in a sense, and the inverse one, that the typical improvement in health in those settings, decreases in under 5 and infant mortality, will have a transient but important increase in population. Okay, this creates larger cohorts that have to go to school. Then this eventually creates larger working age cohorts. And the challenge in these settings is that the evidence that Ines was talking about really be marshaled so that these larger cohorts of more surviving children are educated. You create a modern workforce, and then you should have labor market policies that mobilize this extra labor so that it's put together with capital equipment and land in ways that actually increase economic growth. This, to me, does not mean that in these countries there are no co-benefits, and does not mean that in these countries the association mostly goes to income, to health, and not vice versa. Yesterday, one of the economist who won the Nobel Prize, one of the economists who put forward this argument. So I'm a bit, it's difficult to challenge this conclusion in a sense, but I do think that in these settings, the co-benefits are conditional on the right educational and labor market policies. This means that it may be more difficult to create synergistic policies to reap them, but not that they don't exist. In high-income countries, many co-benefits revolve around making healthier people that are already working, and here the benefits and productivity are pretty direct, I would say. So this is a more direct effect in a sense. But The main difference, I would say, in terms of development level, stage of development, is that there would be maybe more synergy needed in some contexts than others to actually activate, let's say, these co-benefits and reap them.
Thank you very much. I love a really bold prediction. I love that. So, Ines, are you going to make bold predictions too, or are you going to be more conservative?
I must. That was hard to beat, Matteo. So I'll be a bit more conservative. It's given that you started off with the third question on national identity. Maybe I'll reverse. I believe the second question that Astrid presented was having identified the impact of health and education, what measures are you working on to reverse the negative impact, and is there a quick fix? So yeah, I think when I'm thinking about measures when it comes to the impact of health on education, I kind of bucket them into three buckets. I think the first is a case of prevention type policies. So if you think back to one of the first slides about the impact of negative shocks on in utero health, so things like your mother being exposed to, say, a famine or a war. So what are the kind of like preventative things that you could do from a policy perspective to essentially avoid those harms from happening? And that doesn't just happen in utero stage. It can also apply to things like exposure to diseases and virus and so on. So prevention is the kind of first measure. I think the second thing is to think about access. So, so as we all know, healthcare is one of those things that is unfortunately somewhat unequally distributed, and in particularly unequally distributed in some countries more than others. So what are the kind of measures that we can take to improve access so that when needed, people get the interventions that they need? Yeah, in relation to the findings just now, example of this would be, the low birth weight babies having the medical interventions that would be beneficial in the long run. And then the third type of measure, I would consider that to be more knowledge-based or information-based. So one example of this would be the water and sanitation programs that I mentioned in the slide about childhood health. So on the one hand, you can think about water and sanitation as a big infrastructure project and making sure that clean water runs out of pipes and so on. But in high-income countries, those kind of interventions, actually, it's more common to be a knowledge-based intervention, meaning that it's a case of reminding teachers and students the importance of washing hands and whatnot. And it's, there's a lot of evidence showing those interventions, those knowledge/information interventions are surprisingly effective. So yeah, in response to Margaret's second bit of her question about a quick fix, I would say the quickest fix when it comes to comparing these policy measures would be these knowledge/information-based policy measures.
Okay, thank you very much. Scott, you're one that likes to be bold, so I'm going to come to you next. Bold predictions and quick fixes.
Well, I've been thinking that Ines just did a great job, and I was jotting down notes. So I suppose I would honestly refer back to the previous speaker, but I think the really short way you would want to present this to somebody in policymaking is think about the best buys for each of these, right? If your problem is something very basic like infections and parasites, go there. But on the other hand, there's something at every stage, such as, for example, the prevention elements that Ines was talking about, which are amenable to policy in any country. And this is one where you could really combine health expertise on what does the best thing for health with this increasingly solid literature on, once you have better health status at a given point in the life course, how is your human capital improved?
Okay, thank you very much. Luigi, is there anything you would like to add as I'm coming round all the panelists?
Sure. Yeah. So on the question of the low and middle income countries, I mean, we took like a global perspective across the special issue. So there is quite a lot of evidence across the globe, so including low and middle income countries. So this is clustered on certain topics. For example, universal, the article on poverty covered the literature on universal health coverage expansion, which is concentrated on low middle income countries with some interesting findings there, which shows that, without the insurance expansions improves access and reduces out-of-pocket payments, but sometimes it uncovers unmet needs. So it's quite important that you have the supply that is heavily regulated, or at least regulated to some extent, to make sure that this translates into this reduction in out-of-pocket payments. So yeah, I think that's all I want to say on that round of questions.
Okay, I'm afraid we don't really have time for another round of questions, which is unfortunate, but that's the way the cookie crumbles. So I would just like to thank everyone for coming. It's been a fantastic series of webinars. We've had some amazing discussions. I think you'd all agree we've had some brilliant speakers as well. And as one of the co-editors of the special issue, I would like to hand back to Luigi so that you can tell us what our takeaway messages should be.
Yeah. No, yeah, it has been really amazing to edit this special issue. I'm very grateful to the authors that have done all the work. There are 2 points here again to reiterate that we hope that this is useful. We have the evidence on the co-benefits. I think COVID showed that health and the health system has an impact on the economy. And so that gave a momentum to invest in health systems. Now the budgets are being squeezed again. So in that sense, that momentum seems to have gone. On the other hand, we have this very long waiting list that we are accumulating across the countries. And if you're thinking about all those patients waiting that are maybe outside of the labor market while waiting to get healthcare, well, that seems to be one co-benefit that we have well documented. So I think maybe that confirms that we can use this evidence to keep focus on investing in health, hopefully. Thank you.
Thank you very much. And so with that, I would like to thank everyone in the audience. I would say join the mailing list. And I look forward to seeing you in the next group of webinars here in the European Observatory on Health Systems and Policies. Thank you very much, everyone. Thank you very much. Bye-bye.